Thank you so much. I am Michellene Davis. I am the president and CEO of National Medical Fellowships, and I am a social impact advocate, a health
Mm.
equity evangelist, an equity innovation strategist that is trying to make true impact as the CEO of NMF.
But I loved all those titles. Does that all fit on a business card? Or do people even do business cards anymore?
I don't know. I do them electronically.
I think it feels like people who are paying attention to the all the things you just mentioned, that's new. It it's new in the sense that it's more in the conversation that people are paying attention to this, that corporations have DEI executives. We have it's a part of who we are and how we run our organizations. I'm curious, how did you get to where you felt you needed to start an entire organization to address this?
So I will tell you this. While in fact I haven't started this organization, the organization has been around for 80 years. I will tell you that I come to it as a result of being in healthcare and government and a lawyer for a long period of time. Right. And so what I found was that so often decisions were made in rooms about communities and families and members of systems that were not in the room and didn't
Mm,
have a voice, right? So what I noticed was that in the higher echelons of both corporate America and government, there seems to be oftentimes an ineffective ability to ensure that those for whom we are thinking about or planning for or adjusting protocols, practices, and procedures around, that they were not centered. Their voice was not in the room, at the table, or being heard. And so for me, it really came about as a result of navigating a healthcare space and understanding, watching and seeing so many family members and other community members that really were not a part of the solution to the problems that they were addressing.
can you give us an example?
Oh, wow. Which one would you like? All right. So I'll try this one. What I will tell you is that in large scale academic healthcare systems, there is a tendency to be really celebratory about recruiting a new physician from halfway across the country or halfway around the world, right? A lot of celebration about that. And yet, oftentimes, there is a need in the local economy to employ more individuals locally. One of the things that I often
Mm,
found was that there were decisions about hiring practices which were exclusive of the desire to ensure that the economic engine that is a hospital or a healthcare system was literally utilized in order to lift the community in which it's at, right?
mm,
Which
mm,
means
mm,
that you
mm,
have a
mm.
direct and deliberate effect at really trying to drive hiring from that local community. I'll give you another one, my friend. And that is that oftentimes folks talk about the interest or the benefit of diversity, right? And yet the recruitment and hiring processes can lack an effect to actually recruit from those same communities that you're hoping that your workforce is reflective of,
Mm.
right? And so it was really taking a look and looking around the table and saying, well, there's no one here who is of those communities, save me, right? There's no one in that particular department rendering their decision around the creation of a strategy in order to recruit, attract, retain, matriculate, right, persons who are not of the monolithic majority within this country. And so if the teams that are developing the strategies around recruitment are devoid of that diversity, then you're really just having a miss.
I probably fall into a trap of thinking diversity is gender and race and faith. And when I have conversations, I start hearing about cultural diversity and geodiversity and educational diversity and which just I think speaks to my bias probably. I'm curious how do we widen the lens when we say DEI is not this, but it's this.
So I think that we do it by doing two things. One, leaning in and always ensuring that we are saying, yes, it is exactly that to which you have just right reframed, but it is also so much more. So I think that it's really important that folks understand that it's yes and it isn't either or.
Mm,
right? It is not
Mm-hmm.
this or that. It is this and that, right? There's intersectionality that is an element of
Yeah.
this, right? Meaning that I am not just one thing, right? And you are not just one thing. And so it's really the ability to make certain that folks understand that we have the right, we get to be complex, compound individuals and entities, and that in order to really create a culture that fosters a sense of belonging in entities, especially in healthcare, you need to make certain that you're not cutting it off at just this or that, but saying this and then the other thing as well, right? All of that diversity is what literally has been shown to improve both the bottom line in corporate settings, but also in clinical care.
Mm.
Evidence, yeah, absolutely. The studies literally lead to the fact that the greater the diversity of a clinical care team, right, the greater the innovation of that care team, the more likely and the higher aptitude actually to ensure that there is longer time spent at the bedtime, that there's actually strategy discussion around whether or not you have access to the insurance in order to actually fulfill the prescription that you're being given. This is a type of diversity that we're talking about, the diversity of thought in and of itself, which oftentimes comes from the diversity of lived experience. And that lived experience is reflective of all of the components of diversity that you've just mentioned.
Why, with as many benefits as you just outlined, just gave us a really great list that we could dig in, and I'm confident you have examples of bottom line examples and all kinds of things that you could help us on team cohesiveness and morale and reducing employee turnover and all of those things. Why is just the idea of paying attention to this such an uphill battle?
Oh, I love the question. I will tell you, I think that oftentimes one of the challenges is in having to decenter ourselves, right? And so when you say, why is it such an uphill battle? Oftentimes it is difficult to even get the attention of executive leadership to understand that your soul experience is not the experience of everyone else. And that soul experience, right? The way in which you experience the world is not uniform. Because for a long time, right, Mark, it's been permitted to be. And so being able to say, not only is it not uniform across the board, but quite frankly, it isn't healthy, not for you or for the institution, right, to which you serve. And as a result of that, we have to ensure that at the leadership level, we are bringing in other individuals who do not have a monolithic experience, right, through their lived experience, through their educational experience, right, through just the way in which they have experienced the world, in order to ensure that your entire culture of your organization, of your healthcare system, of your hospital, of your academic medical center system, of your medical school, is really that which is a tapestry that evidences that all of this lived experience, all of these lives, right? And this, my friend, I'm thinking about the hierarchy of human value, right? That in recognizing all of them, you are actually weaving together a tapestry that will help to create an entire environment of belonging for, yes, the students, if they're medical students, but for your employees and your clients and your vendors, and most important, your patients, right? Individuals can walk into an environment and sense whether or not they are welcome. Tell me that they cannot, and I will tell you that they can, right? I bring to you, yes, a background of being a CEO here and having been a state treasurer and a variety of other things, but I also bring to you a PhD lived experience of being a Black woman in this country, right? And so I bring that for free. And as a result, I can tell you about the times in which we oftentimes can enter a space and know almost immediately that this is not an environment in which I am welcome. This is not an environment that's been created and cultivated in order to curate an experience in which I can thrive, that here I'll have to struggle in order to survive.
So I admittedly don't get out as much as I'd like. You travel a lot. Tell us, I live in Santa Barbara, and this is a bubble here, so it kind of doesn't count. And I'm going to eliminate the coastal elites as well. If you were to give us a report card on there's 400 healthcare systems in the United States, the big ones. what percentage of them would you say you could walk into and have that good feeling we just talked about?
Wow. So I have to take it one step back in order to really be fair to our viewing and listening audience. And I have to be able to codify this through the actual history of, right, persons of color in this country and forced experimentation, right, and
Oh,
exploitation
sure,
in the
sure, sure,
medical
sure.
industry, right? We've got to acknowledge that. And I say that because many individuals from all walks of life actually experience kind of white coat syndrome, right? You walk into a doctor's office,
Mm,
you may actually feel that your heart rate gets a little higher, right? Your breathing, that pacing alters, it has changed. You feel a little nervous, etc. Well, for certain groups of this country, for certain individuals who are of communities that have been marginalized and historically disenfranchised, they've also been intentionally exploited. And so when we talk about
mm,
walking into an environment, which quite frankly was the right, these environments were the authority spaces for this exploitation.
yeah.
Being able to say, where do you feel like you have that that welcomed feeling? I have to make certain that I'm fair and talk about that history also comes with us, right? Most individuals say, well, it happened so long ago. Did it? Did it? Because right, forced sterilization was still happening up until right the 1970s. Like I don't want us to slip up for a moment and think that because history is often presented to us in black and white photos that anything was a long time ago, because it is not, right? It was not, right? We know about that. We know that there was both uninformed hysterectomies, right? That there's been forced sterilization. We know about everything from radiation treatment on African American children in order to treat head lice, which they did not even have at the time. We know that there's been a lot of this, and these individuals who were the subjects, quote unquote, the victims actually of these experiments, right? Their families are still with us today,
Mm-hmm, mm-hmm.
right? Henrietta Lack's family, HLA cells, right? They're still fighting right now. So the issue that I present there is that, when you walk into especially a healthcare space, you do walk in with the knowledge of that history, right? And so that one is a little bit more than just, are they actually doing what they need to do in the space of ensuring a sense of belonging? Are they also digging deep in order to develop a level of trust to overcome a well-earned history of mistrust in the communities that they serve? And if in fact they are doing that, then yes, I do feel welcome.
So take a little different tack. You run an organization, which is a policy organization, I guess, and an advocacy organization, and an information and doing things like this to get out there and inform people. And the more educated we are, the curious among us will change our attitudes. That's one of the great things about the TED platform is ideas change everything. So having an idea will help. And I'm going to guess, and I don't know that you can speak to this, but this issue is not isolated to the United States.
Oh, I'm certain that it is not. As a result of, quite frankly, our global history, I will tell you that exactly what you just described, how ideas change everything. It is one of the reasons why at National Medical Fellowships, the idea about how do we literally ensure that we are pushing back against this history of mistrust, well earned. And one of the issues there is to ensure that we have clinicians who represent, who come from, and who look like the communities that we are serving,
Mm,
right? And so National Medical Fellowships has been doing that for 80 years. We have literally been ensuring that those who come from communities that oftentimes are pushed to the margins, those who are Black and Latino and certain Asian categories and Indigenous, that they actually have the opportunity to fulfill their dream of becoming a physician, right? And that we do that through, yes, there is sponsorship and there's scholarship and there's mentorship, but it's really about creating the community around them that offers that support so that when they
mm,
are literally in schools, which are oftentimes, right, these same entities that we've just talked about, that they literally have the support, that they understand that there is an entity that is rooting for them, who sees them, understands that they are brilliant, and that they have well earned their right to be in those schools. And then we help to bring them over into the other side, right?
I have a little different question. So when I think of a large healthcare organization, I think of a board of directors. I think of the upper management, not the operational management, but kind of up here. Where is that where you're working? Is that where you're trying to have the most impact, or is it more of a bottom up approach?
So that's really interesting. And I will tell you this. You know that I have been a healthcare executive. You know that I did that at a large scale academic medical center system for nearly 15 years. So, what I will tell you is my answer is a yes and. I came to National Medical Fellowships not to just create more Black and Brown physicians because of the fact that we are already facing a worldwide shortage of physicians, right? There's a new study out by Mercer that says that we look to be at least 100,000 short of physicians by 2028. There's another study out that talks about that significantly by AAMC. But so this is why I came here. I came here to create more physician leaders. And that is so that it is both at the healthcare executive level, leading these systems and these structures, as well as ensuring that there is a pathway through which these students can then get through medical school and begin serving the communities, right, that they come from and the communities that need them the most, right? And so literally it is a yes and to your question, my friend.
So, it's a kind of a final question. Do you feel hope and optimism as you get to work each day in terms of making a difference out there?
Absolutely, positively, yes. First of all, Mark, you have to know this. I'm a hope dealer, right? So I firmly believe, listen, every time I come to work, every pen I pick up, every piece of paper I put down, I believe fully that there is not just an outcome or an output, but an impact that we are having. And I know it because we've been doing it since 1946. If in fact the issues that were present in 1946 that caused the need for national medical fellowships to exist were eradicated, then we would no longer be here. But the truth is that we still have vast healthcare disparities in this country. We still have implicit bias in medicine. We still have structural racism that we have to overcome from policies and systems and laws that have set up an equitable existence. And so as a result of that, I know firmly, do I look forward to it? Am I still enthusiastic? Do I believe that we have a chance to change this, to make a difference? You bet your bottom dollar, my friend.
Thank you so much for preaching right now to us and helping our TEDx Santa Barbara audience understand the power of this.
Thank you.